Good evening, everyone. I'm Dr. Seng Kiong Fang from Kuala Lumpur, Malaysia. I'm the current president-elect of Asia-Pacific Glaucoma Society. It gives me great pleasure to moderate this master class given by Professor Tin Aung entitled Imaging in Primary Angle Closure Disease. First of all, I would like to just introduce a bit on our Asia-Pacific Glaucoma Society. Can I have the next slide, please? These are the member benefits for APGS. Mainly, you have a registration discount to attend the Asia-Pacific Glaucoma Congress, which will be in Kuala Lumpur this year. It's a hybrid meeting from August 5th to 7th. And you have access to our online education platform with recordings of the APGS webinar series, including this one, and also surgical videos. And we have quarterly newsletters, access to online communities, and also free access to the Journal of Glaucoma. And the rest is the rights to our electoral process and able to participate in the activities of the APGS and international affiliate societies. Can I have the next slide, please? Yeah, and this is just an example of the APGS webinars that we have been having for the past 2 years, and including our master classes. Next slide, please. And I would like now to introduce our speaker, which is Professor Tin Aung. He is no stranger to all of us. He is Chief Executive Officer of the Singapore National Eye Center, and also the academic chair, the Eye Academic Clinical Program of the Duke NUS Medical School. He is also the Kwan Im Tong Hood Cho Temple Distinguished Professor of Ophthalmology of the Duke NUS Medical School, Senior Consultant at the Glaucoma Department SNEC, Principal Investigator and Chairman of the Board of Singapore Eye Research Institute. And Professor Tin Aung is a clinical scientist, and his clinical practice focus on glaucoma and his research interest in angle closure and glaucoma genetics. And he has published numerous papers and also received numerous awards. And he is also a member of the editorial boards of the Journal of Ophthalmology, Glaucoma, Progressive Eye, Retina and Eye Research, Graphy, Archive for Clinical Experimental Ophthalmology, and 6 other journals. And he is the past president of the World Glaucoma Association and currently serves as a board member of the Asia-Pacific Glaucoma Society, and also the president of the Asian Angle Closure Glaucoma Club. So it gives me great pleasure to ask Tin Aung to start today's masterclass on imaging on primary angle closure disease. Over to you, Tin.
Thank you. Thank you so much, Seng Kiong. I'd like to welcome everyone to today's webinar on anterior segment imaging for angle closure. I have these my disclosures, but not relevant to the talk. I come from Singapore, and these are some photos of Singapore. So angle closure glaucoma is an important form of glaucoma, especially in our part of the world. It affects more than 30 million people. Angle closure glaucoma is also unique from open angle glaucoma because it's primarily a disease of the anterior segment. So the anterior segment abnormality results in high pressure and eventually results in glaucoma. And so we need to make the right assessment of the angle in order to make the diagnosis, in order to document our findings, and also to look at the mechanisms or subtypes of angle closure. And for that, we often use imaging. Clinically, we need to assess the angle by gonioscopy. And as I said earlier, if we don't make the angle assessment, you will treat the patient as open angle glaucoma. So you almost always do a gonioscopy on every single one of your patients in order to discern is it open angle or closed angle. And gonioscopy is a simple clinical technique which relies on directly visualizing the angle structures. Now, many of my juniors are often confused when they do gonioscopy because they read about all the different classifications and the different grading systems of gonioscopy. But really, do not get confused by these systems. Just remember, when you are performing gonioscopy, you are trying to determine one thing only. Is the iris opposed to the trabecular meshwork? And because if the iris is opposed to trabecular meshwork, that signifies that the iris may obstruct the trabecular meshwork and close the angle and result in aqueous building up and the pressure going up. So it's one aim only, is to determine is the iris opposed to the trabecular meshwork. Unfortunately, we also know that gonioscopy is not performed for many patients, and this is because many doctors are not familiar or not confident of their findings. In fact, even in the US, only about 50% of open angle glaucoma patients had gonioscopy performed. And there are some issues with gonioscopy. It's very subjective and variable. It varies according to the observer, the light conditions that you use. You have to do it in a dark room and not in a bright room. And even when you perform the slit lamp examination, the light should not be very bright and shining on the pupil, because if it does happen, then the pupil will constrict and then you may artificially open up the angle. It also varies according to the lenses that you use, how hard you press on the eye. And there are also some problems often they're not, the recordings are not standardized in terms of how you document your findings. And as I mentioned earlier, it's not easy to teach a junior how to do gonioscopy well. And so we have some interest in imaging. As you know, ophthalmology is full of imaging modalities. And just like we do imaging for the retina, we can also perform imaging for the anterior segment. And here I will be going through some of the different forms of imaging that we use in our clinics today. Firstly, I will start off with UBM, or ultrasound biomicroscopy. And this is a B-scan system which allows viewing and acquisition of images under magnification. And usually the resolution is 25 to 50 microns, as you can see in the picture on the left. It's not a very high magnification, but it's a useful way of imaging the angles. It's also able to see structures behind the iris, such as the ciliary body and the choroid, because it has good penetration. The problem with UBM is that the field of view is quite small, so you can only see that small area that you're imaging, and it requires a skilled operator. Often, if you don't know how to use UBM and you start doing for the first time, you may not be knowing what you're doing or where you're looking at. And also, it takes some time and it requires some contact with the patient. There are various forms of UBM available. Most of them have some contact. It could be either with a water bath, or some of them have the water bath embedded in the probe. So it is not that easy to perform for most people. And in a busy clinic, they don't have time to do a detailed UBM examination. We now move on to OCT, and just like you use OCT for the retina, there are OCT devices for the anterior segment. The earlier device was called a Visante, and you can see here, it obtains cross-sectional images of the anterior segment. You can see the cornea, the iris, and the anterior lens surface, and the angles. The resolution is good, about 10 to 20 microns. It's non-contact, patient is sitting up, and the acquisition is immediate, like within 1 second, it will take the image. Now, when you see an anterior segment OCT image, there's two ways of analyzing the image. One is subjectively looking at the image and deciding is the angle closure. And the second one is doing measurements of the angle. Now, in most clinical settings, we don't have time to do the second one. And so we need to do the first one, which is we look at the image and we decide is there open or closed angles. And as I said earlier, what we're looking for is apposition of the iris to the angle. In particular, we want to see if the iris is opposed to the trabecular meshwork. But the problem with most anterior segment OCT devices is that you can't see the trabecular meshwork as a clear image, not like in gonioscopy. And so we use a landmark, the scleral spur. And if you can see my arrow, if you follow the inner surface of the cornea, and then you follow the inner surface of the sclera, they meet at this arrow here, and this is called the scleral spur. And we know anatomically the trabecular meshwork lies just anterior or in front of the scleral spur. So this is where in this area is where we expect the trabecular meshwork to lie. So it's like we have to guess a little bit, because most of the time you can't see the trabecular meshwork clearly in the image. And remember, I told you it is a histology here. You can see the scleral spur in blue, and the trabecular meshwork lies usually within 500 microns of the scleral spur. So in this example here, if you follow my arrow on the left-hand side and you follow it all the way to where the sclera, inner surface of the sclera meets the inner surface of the cornea, the scleral spur is demarcated by this arrow here. And where is the trabecular meshwork is, as I told you earlier, it's anterior to the scleral spur, so it's in front here. And here there's obvious contact of the iris with the area anterior to the scleral spur. And so this would be called angle closure, because you expect the trabecular meshwork to lie there. And similarly, on the right-hand side, if you follow the inner surface of the cornea and the sclera, they meet here, and there's contact anterior to the scleral spur. So this is a closed angle. In this example here, you can see the scleral spur is somewhere lies around here, and is very wide open. There's obviously here, you can see the scleral spur here. If you follow the inner surface of the sclera in the cornea, there's no contact, and this is an open angle. Another example here, you follow the inner surface of the cornea and sclera, they meet here, and there's a lot of contact here, and you assume that's where the trabecular meshwork lies, and this is angle closure. And on the right-hand side, again, you follow it inside, and this is where it lies, and this is angle closure. You can also make measurements of the angle relative to the scleral spur. And why do they make measurements relative to the scleral spur? Is because the meshwork lies anterior, and you can make measurements such as here, the angle opening distance, 500 microns from the scleral spur. This is where you expect the trabecular meshwork to lie, or the angle recessed area is shaded here. So these are all measurements as well. So what are the disadvantages of anterior segment OCT is, firstly, as I said earlier, you can't visualize the trabecular meshwork. Also, you can't visualize the ciliary body. And the disadvantage is that you are only limited to one cross section at a time. So if you take one image, it's one cross section. You're unable to indent to look for PAS, unlike in gonioscopy when you can indent. Sometimes there's limitations in the angle software. And finally, you can't seal a scleral spur in about 20 to 30% of the cases. So here's an example here on the right. There's no obvious scleral spur because it seems like it's continuous. The iris and the inner surface of the cornea and the sclera continuously. So you don't know where the scleral spur lies, so you don't know where is there angle closure or not. So sometimes if it's a smooth continuous line, you don't know where the scleral spur is a landmark. So the scleral spur is here, is obviously open. But if the scleral spur is here, then it's closed. So that's why there's a bit of variability when it comes to scleral spur assessment. Now, we've been working on, and other groups as well have been working on automated classification systems for anterior segment Visante images, and this is one example here. So what we try to do is use machine learning to automatically learn how to grade images. And this is a software which we have used for a few years. And basically, the machine learning will look at the image and say, oh, this is open and this is closed, and they demark it by green for open and closed is in red. So here green is just open, this is temporal, and N is nasal. And the machine learning will tell you automatically, is it open or closed? And here is another example where it's automatically will tell you, is it closed or open, and using a red for closed. So this is an example of automated software. And now we move on to currently we use a spectral domain OCT, or it's called high definition OCT. And this is a higher resolution than the original Visante. And here you can see much more high resolution. Here you can see, for example, the trabecular meshwork, you can see the Schwabe's line. And this is called a high resolution scan of the high definition OCT. And here you can see here obvious trabecular meshwork here, scleral spur, and obvious angle closure with contact. And here you can see peripheral anterior sinus. Okay, but this is called a high resolution scan. But the basic scan of the serous anterior OCT is just like the Visante. You obtain images like this. And again, you have to look for the scleral spur and to determine is it open or closed. And the serous actually can be used for the retina, and you put an external adapter to a lens to attach to the front of it, and it will change the scan from posterior segment to anterior segment, and it obtains an image like this. Now, in the serous scan, you often see like a blue band in the cornea, and this is because there's a reflection here, as you can see on the left, and the software will erase that reflection, and that's why sometimes you can see these blue bands. This is from the software erasing of the reflection. And the serous can also be used to rotate to different quadrants or different axes. And are there any differences between the serous and Visante? Well, actually, we published a paper on this, but there's very minimal differences. You can see here, resolution-wise, it looks a little bit different, the color a little bit different, but otherwise, the measurement-wise, almost identical. And the serous also has another scan called the high-resolution angle-to-angle scan, and the high-definition scan here, which I showed you earlier, images of, where you can see in much higher resolution. Now we'll move on to another type of OCT. It's called the swept source OCT, and this is much faster. It's like 1310 nanometers and uses 30,000 A scans per second. So it's a much faster system, and it also has 360-degree angle imaging. So this is called the Tomei Acacia, the swept source OCT, and here you can see high resolution scans here, and this is one of the type of scan where you can see the trabecular meshwork, Schwabe's line, and scleral spur. And they also have a 360-degree angle view. It's a very beautiful angle view here, but actually this view is not used clinically. It's not that, it looks very pretty, but it's not that useful clinically. What I like to use is this scan here, and see this is a 360 scan here, and you can see this arrow on the left here going around in 360. So basically it's a video, and let me play the video again. So what happens is this is a scan showing you a composition of all the different scans around 360 of the eye. So this is called a 360 scan. And what it consists of is actually 128 slices. So you can see the arrow here in yellow is actually going around the eye and taking 128 slices of the eye. So they will take you almost a very nice overview of the angle. So basically you consist of 128 scans and you will see 256 angle images. Okay. Now, of course, in clinical setting, you're not going to look through all 256. It's too much work. So usually we'll catch a few images and take a look to see if there's angle closure. Okay. Now, the Cassia also has a software called the ITC index, where you can measure how much of the angle is closed by marking out the scleral spur on each image. So you have to take at least a few images, and then you mark out the scleral spur, and then they'll calculate how much of the angle is open or closed. And from there, they come out with an index, and it'll tell you which part is open and which part is closed. So this is a software that they have as well. We have also worked on a different software. It's like a Singapore software. Basically, as I showed you earlier, we have a machine learning which can grade open and close in any one single image. So what we did was with this software then in parallel analyzed all 128 scans. So basically, you analyze all 128 in parallel and then come up with a summation. So basically, it's a summation here, and it will tell you where is open and closed and which part is open and closed. So this is a summation here on the left. It will give you the where it's closed, and here is the overall summary. So this is a software which can be applied to the Cassia. And Cassia also can show PAS, example here, it can show document PAS. Now, we've also looked at it and before and after surgery. For example, if you do goniosynovitis, you can document reduction of the PAS to see what the changes. Now, let's move on now to other newer devices which may be coming onto the market. This one called the hyperspectral OCT, which actually is supposed to be faster, but honestly, I look at the images, it doesn't seem to be much superior to current OCT images. Then you also have angle photographic methods, and here you have something called the 360 angle gonioscope, or by NIDAC, and basically it's an instrument that becomes close to the eye, and then it takes multiple photos of the angle in 360 degrees, and basically you can look at it either by quadrant or looking at inches. It's basically like a gonio photography system. So it's something which could be also clinically applicable, but at the moment it's not widely used. And right now they don't have a software that can help you analyze these photographs easily. Okay, but this is something which is available, and they take a variety of gonio photographs per eye. It's almost done quite quickly, like 1 second to acquire, and you get a quick overview of the gonios, of the angle in 360 degrees. So this is what it looks like. Okay. We are working on a device called a gonio pen. It's a low-cost device. Basically, it's a black and white probe which can hold something like a UBM, and you can take images almost like a gonio image, like this here. You can see here on the left, something similar to a gonio photography as well. Now let's move on. Now we've gone through now all the different technologies, and now we'll look at what is the imaging used for. So as I told you earlier, firstly, it's very useful for making the diagnosis correctly, okay, and especially if people are not sure or confident of the gonio findings, you can use the imaging to get an idea of the angle status, okay? And it's very useful to document as well. In my clinic, often if the patient has got angle closure, I would use imaging to document it, and you can explain to the patient what the patient has, and also you can see over time changes with treatment, for example, after laser iridotomy or even after phacoemulsification, and these are very useful to document. Nowadays, you know, we document a lot of things. We take photographs, we take scans, and etc. So it's very useful. I don't do imaging for every single patient, but definitely those with angle closure, I would do imaging, and just to document it, and as I said earlier, to show the patient and they understand what's going on. And then we'll go also a little bit into mechanisms and subtypes. Now, let me move on to a little bit about risk factors. And basically, using imaging, we have found that there are new risk factors for angle closures. For example, we found that the iris is associated with angle closure risk. Now, this is perhaps not surprising. Basically, the thicker the iris, especially the peripheral iris, the greater the risk of getting angle closure. So you can see the picture here, a patient with a thin iris and a patient with a thick iris. Obviously, the one with the thicker iris, because it's thicker, you'll have a higher chance of getting angle closure. And similarly with iris cross-sectional area, we find that a lot of angle closure irises are not only thick, but they are very fat and wide, like you can see in this example, right? So this is an example of an iris mechanism. And this is a paper we published about 10 years ago where we looked at different iris risk factors, including iris thickness, iris area, and iris curvature. Now, just like anterior chamber depth is an important risk factor, we also know that anterior chamber width is important. So not only the deep eyes or the shallow eyes, but also the smaller eyes. So the smaller the anterior chamber width, the greater your risk for angle closure. So again, if you see a patient with small white to white diameter, you have to think of it as a patient at risk of angle closure. And similarly, the area and volume. Now, the lens vault is another interesting parameter. So the lens, as you know, plays a major role in angle closure, but particularly, we found that the most important lens feature is the lens vault. So basically, if you draw a line across the angle at the level of the scleral spur, the lens vault is defined as the part of the lens that's in front of this angle-to-angle plane. So basically, it's a part of the lens that's jutting into the anterior chamber. So as you can see here is the lens vault, only the anterior part. It's different from lens thickness, which is the whole lens, and it's different from lens position. So some lenses are very thick, but they don't jut so much into the anterior chamber, then it's not so important. Some lenses are quite thin, but they are jutting a lot into the anterior chamber, and this could be an important risk for angle closure. Now, what this shows actually is that angle closure is not a single disease. It's not a homogeneous disease, and there are different anatomical factors in different people, okay? So some people, it could be a small anterior chamber, shallow. Some are small angle to angle or anterior chamber width. Some are thick iris, and some are big lens vault. So these are different. And in fact, we asked this question, are there subgroups of angle closure? And actually, we found that there are actually 3 subgroups. Okay, one subgroup are the thick irises, which we were surprised to find is quite common, maybe about 30% of people. Another group are the large lens vaults. These are about 10%. And then they have a mixed mechanism where you have shallow anterior chamber plus other factors. So the thick iris alone could be the anterior chamber is normal, but the iris is very thick. And actually, we looked at this and we published this about 8-9 years ago. And we also looked at whether we could identify the mechanism based on some kind of algorithm. And basically, we looked at this algorithm, which would automatically grade anterior segment OCT images and then come up with a single, not only the close and open, but also tell you what kind of mechanism it is. Okay, so this is an example of an image which will take multiple features and it will tell you the risk for angle closure and also tell you what is the main feature. Is it the thick iris, anterior chamber, or the width? Yeah. Now let's move on to angle closure mechanisms. As you know, pupil block is the main mechanism of angle closure. And here you will see pupil block. There's resistance of aqueous flow at the level of the pupil. The aqueous builds up behind the iris and you get a convexity and closed angles. And this is well documented with the UBM here, as you can see here. And after you do iridotomy, you create a bypass of the aqueous. You will see here the angle opens up and the iris convexity reduces. So this is a pupil block mechanism. And here's another example where after iridotomy, it opens up, and the below example, no change, because this is a non-pupil block mechanism. So using imaging, you can document treatment of changes. Here's an example on the left, where after iridotomy, the angle opens up slightly, and after phaco, it opens up significantly. Okay. The next mechanism is plateau iris, and plateau iris is basically where the ciliary body is anteriorly rotated, and this causes pushes the iris against the angle. And here you can see an example of plateau iris, and there's loss of the ciliary sulcus in C, and you get angle closure, and the iris has got a bit of like a different angulation here. And these people, typically, the anterior chamber is not so shallow. In fact, centrally, it can be deep as well. And this example of plateau iris, this is again a variation in anatomy. It's a variation in ciliary body anatomy. And this can be diagnosed easily with UBM. Now, looking at, once you find plateau iris, you can also look at treatment options. For example, we know that iridoplasty can reduce angle crowding from plateau iris. Here's an example of a patient who underwent iridoplasty. And here's the clinical, here you can see the iridoplasty shots. And basically, these are large spot size, slow and low energy burns. And this will open up the angle. I mentioned to you earlier the lens component, and here's again an example of a patient with a very large lens vault. In these examples, you have to take out the lens. There's no use doing other treatments. You must as well do phacoemulsification to remove the lens. This is a clear lens component. And so angle imaging, for example, is useful to look at the lens vault and to do phacoemulsification. Sometimes even the vision may be pretty good, like 6/9, for example, but with a large lens vault, you recommend early lens removal because these are the people who will benefit from the lens removal, those with a large lens vault. Okay, so in summary, I've gone through today, in today's class, an overview of different imaging modalities for angle imaging, angle closure imaging, and most of them are easy to perform, and there's also quantitative assessments. I've gone through you the advantages and disadvantages, and I've also talked to you about some of the future directions, including 360-degree angle imaging, automated analysis, and goniophotography, and of course, use of these imaging devices clinically for documentation and looking at mechanisms. So these are acknowledgements of some of my colleagues on the top left and some of my collaborators on the bottom left. Thank you so much for your attention.
Tonight.
Thank you, Tin, for excellent overview on imaging of primary angle closure. Now it comes to the time of question and answers. I would just like to ask Tin again. You mentioned that the gonioscopy is very important. So with the advent of all these imaging devices, do you think that one day we may not need to do gonioscopy?
Yes, I think it depends on the setting. If you're in a general ophthalmology clinic or you're a solo practice, maybe you have to do gonioscopy. But certainly in an institution setting where you have lots of devices, I think imaging can technically be first pass, and then you probably can do gonioscopy, for example, to confirm some of the imaging findings, look at PAS and other clinical things that you can't see on imaging. Yeah, so I would think it could be like a first pass. Yeah.
Okay. Yeah. Again, we would like to stress again that clinical examination gonioscopy is still the mainstay. But with if you have like imaging devices, automated gonioscopy, I think in the future these machines might be able to replace. But again, we would like to remind everyone that these are very expensive devices and may not be available in every clinic. How about UBM, Tin? Do you think the anterior segment OCT, the spectralis, and the high density, the new imaging modality can replace UBM?
No, I think the UBM is different because it can be used to see structures deeper. For example, the ciliary body and the choroid, which you can't see with the OCT devices. So I think it's going to be difficult that is to use them for looking at the choroid or the ciliary body. And certainly, I think on a routine basis, I think imaging with the OCTs are much faster and more convenient to do. And the UBMs are still used very much in our hospital, mainly like looking at zonulysis, for example, people with unstable cataracts, other mechanisms in angle closure such as malignant glaucoma and other things are very useful using UBM. Yeah.
And also plateau iris.
Yeah, plateau iris as well. Yes, that's right.
Yeah. We have a question from one of the delegates. Is there any imaging modality that can differentiate between appositional and synechia angle closure?
Okay, so that's a very good question. I would say overall, I would say no, because it's not easy to differentiate between the two. But in some of the imaging methods, they've been described that you can detect the synechia. But I think this will be, you need to be very good at the imaging. You need to get the right cross section of the angle where the synechia occurs, and it's often you could miss it. Yeah, so I think it's going to be difficult in most settings to see synechial closure easily. Yeah, but as I said, if it's very gross or you have managed to get the cut in the right direction, you may be able to see synechia. Yeah, but I think routinely is not, you can't differentiate easily between apposition and synechia, and also because you can't indent with imaging.
Yes, thank you, Tin, for the answer. And is Cirrus, the spectral domain Cirrus OCT with the adapter, do you think is as good as the Visante? Let's say if
yes, I think it's a similar. As I showed you some images, they take almost exactly similar images as the Visante. Yeah. And it's also, I think because they have Zeiss has stopped selling the Visante, so you just have to you get the Cirrus, and then they have the adapters for the anterior segment, and it's more versatile than having to buy two devices. Yeah.
And you mentioned about the machine learning for the Visante. Can it be applied to the Cirrus anterior segment OCT
yes, it
as
can
well?
Yes, it can.
Okay. Yeah. So is the software available for the Cirrus?
We're still working on it, but we use it. We don't use it routinely at the moment because it's not commercialized yet. Yeah.
But soon it will be available.
I don't know. It's up to Zeiss. Yeah.
Okay.
Yeah.
Yeah. How about the cassia? I mean the cassia
cassia
swab
is a,
source.
again, it's a very costly instrument, and so it's not well. There's the volume is not that high. Maybe centers, a few centers have it everywhere, but it's not widely used because of the cost. Yeah, and again, it's a very nice tool to have. It's got very nice images, but I mean, you have to look at the cost of the instrument. Yeah.
Yeah. Yeah. Another question from the audience: for mixed mechanism glaucoma, is it possible to differentiate inflammatory PAS versus angle closure PAS via imaging modalities?
No, I think it's not possible. As I said earlier, it's not easy even to pick up the PAS easily. Yeah, unless you use the high resolution scan, you can tell. But to look at the mechanism, no, it's not possible. Yeah.
You mentioned about lens vault. So can we use the lens vault to decide whether just for angle, for angle patients with cataract and angle closure, do you think that with that we can just decide whether we need just to remove the lens, or can we use the lens vault to safely say that we might not need to do a drainage surgery for
It's
patients
a good
with
question. I
angle closure
definitely,
and cataract? Yeah.
that's a very good question. I think in any patient with angle closure glaucoma, if there is significant cataract, definitely we should consider removing the cataract, because that will definitely help in opening up the angle. Now, the question is, if there's cataract, it's not so significant and the vision is still good, that is where it's a bit more controversial. And there where if the lens vault is very large, then sometimes this may push you towards early cataract extraction, even if the vision is pretty good. Yeah. But if the vision is good and the lens vault is small, then I would not typically recommend taking out the lens in those cases. Yeah. But definitely for those with significant cataract, we would definitely recommend doing early phaco emulsification, those with significant cataract. Now, in terms of the visual acuity, we found that lens vault and visual acuity, there's not a good correlation. Some people with very big lens vault, the visual acuity may still be okay. Yeah. So it's not like they automatically cataract, everybody with cataract have big lens vault. It's not true. The cataract can vary as well. Some of the cataracts are just uniformly opacified, but not a big lens vault.
So is there software available now? To
No, you have to look at it, I think, clinically and judge and look at the lens vault.
okay. Yeah, you mentioned about the automated 360 gonioscopy by the NIDAC. Is it available now, or is still?
It's commercially available. Yeah, we have bought one in SNC, but we don't use it routinely. It's more like at the moment just for evaluation for research. Yeah, because we don't know how to use it on a routine basis, how to interpret the images and all that. Yeah, because it takes a nice pictures, but to interpret it, we have to look at it scan quadrant by quadrant. We're not used to looking at a 360-degree view. Yeah.
Okay.
It's like the like a retina service or OCT where they unfold it into 360 degrees, but we're not used to looking at it easily that way. Yeah. We're used to looking at it by quadrant, as if you do a gonio.
Yeah, but again, it's expensive.
I don't know the price. I can't remember.
But you mentioned the gonio pen. The cheaper version. Is it available?
No, yeah, we're still developing it.
Okay, so that is much cheaper.
Yes, we hope it's like $10,000, I think.
Okay, that'd be great if it's made available. Is it developed by SNEC or?
Yes, yeah, but we're still working on the prototype.
Okay, good.
There's
Another
a question here. Among PSCS, PSCS patients, which anterior segment OCT parameters would be best predictor for conversion to PSCS to PSEG? Now, that's a very good question, and there are two big studies that looked at conversion from PSCS to PSC and PCG. One was the ZAP trial, and the other one was the Singapore analyst trial. And we are looking at that data now, whether there's any OCT parameters that are predictive. Unfortunately, for the Singapore trial, we are underpowered because the number of people who converted is quite small. And same for the ZAP trial. Of course, as you know, the ZAP trial only had like 4% conversion. So maybe we have been a little bit underpowered. So we don't know. It would be a very good question to know which anterior parameters would be predictive of conversion. So currently the answer is we don't know. Mm-hmm. And the last question is there correlation between AC volume and axial length? And the answer is no. There is not a strong correlation, but there's a weak correlation. Of course, people with very high myopia tend to have long axial length and a deep anterior chamber, but it's not a strong correlation. Now, interestingly, about 10 years ago, we published a series of patients with myopia who have a shallow anterior chamber and very long vitreous cavity and overall long axial length. And we think these are the people who have angle closure, but because of environmental influences, during childhood, they got vitreous cavity elongation and caused overall a myopia shift. But their eye is interesting. They have angle closure in anterior segment, but posterior segment is long with myopic changes. And overall, they have a myopic eye with an extra long axial length. So what we think is that these are people who perhaps in the past will not have got myopia, but because of environmental influences, they got axial length, lengthening of the vitreous cavity. So the point we are making is that don't assume that every patient of your myopes, all your myopes have open angles. We have myopes even with 6 diopters of myopia, they have angle closure. And this is because of these people, shallow anterior chamber, long vitreous cavity, and overall axial myopia.
Yeah. Okay, I think there are no other questions from the audience. Tin, would you like to just add anything else before we close?
Yeah. Thank you so much for your attention, and I hope you have a good weekend.
Yeah, we will go to a holding slide after this before I close with a few slides to introduce our next master class and also our APGC.
Thank you.
Yes, again, I would like to thank Professor Tin Aung for an excellent overview on imaging in primary angle closure. I would like now to introduce our next master class. Next slide, please. This will be held on 14th of May from 7 p.m. GMT +8, and our May masterclass will be by Professor Prin Rojana Pongpun, and he will be talking to us on combined cataract and filtering surgery. Next slide, please. Again, I would like to remind all of us to join us for our physical APGC from 5th to 7th of August 2022 in KLCC. So those who are from Malaysia and Singapore will have a physical meeting, and there will be a fully virtual meeting on the first 2 days and a hybrid meeting on the second and the last 2 days. And next slide, please. We would like to thank you for the participation of this masterclass. Again, I would like to thank Professor Tin Aung and also the MCI team and Delegate Connect team. See you at the next masterclass in May.